much, Navneet Singh ji. Dear trainees, welcome. This has been a long pending demand of all of you. I know it is like 3 to 4 months request by all of you in the DNB academic WhatsApp and Telegram group that you wanted this topic to be covered. I know that nobody better than Professor Sudeep Gupta can cover this. And that's why I was waiting for this topic to be covered by him only. It's one thing to know the theory, one thing, different thing to apply it practically. So we may have a lot of theory information on the germline testing, but how to implicate and then know how to actually adapt to the day-to-day practice and therapeutic use is totally different. For that, you not only need a great scientist, academician, but also you need a great, oncologist who can actually, clinician who can put into this. Nobody other than Professor Sudeep Gupta could have done this justice. So I was waiting for him, and he's so busy, but the passion of teaching in him, is the one which made him take this time out of it. As you know that, as I know, Professor Sudeep Gupta is not just, for everybody, he's a director of ACTREC TMC. More than that, for me, he's a academician, walking encyclopedia of all the studies trial. And what I love about him is he really know what trial is clinically relevant, not relevant, what is meaningful, what is not meaningful, which is the way you have to interpret, and is a master in statistics. You have to hear him speaking and analyzing, the confidence interval, p values, and then hazards ratio. You'll be amazed how clinician par excellence, academician, and a great friend of ours and down to earth person with passion of teaching. Thank you very much, sir, for accepting our invitation. Thank you very much for making time in your busy schedule. Over to you, sir.
Thank you very much, Dr. Somashekar. Am I heard?
Yes, sir.
Okay, perfect. So thank you very much, Dr. Somashekar, for your kind introduction. I already am beginning to feel some performance anxiety after your introduction. I am nowhere near what Dr. Somashekar has described me to be. I am just a medical oncologist at Tata Memorial Center, and my areas of interest are breast and gynecological cancers. First of all, I would like to thank Dr. Somashekar and Mr. Navneet Singh for the opportunity and privilege of interacting with so many students. I hope I will be able to convey to you maybe in the next about 35 to 40 minutes some sense of this theme, which is titled Therapeutic Implications of Germline Testing. And I believe my colleague, Dr. Rajiv Sareen from Tata Memorial Center has already had a session on the basics of germline testing. So I will assume some at least passing familiarity with this topic. So those are my disclosures. Let's start with a case. We have a 34-year-old unmarried woman who's diagnosed to have a left adnexal mass with ascites and peritoneal deposits. She has no siblings and there is no family history of cancer in any other family member. She's diagnosed to have ovarian cancer clinically. She undergoes surgery and the pathology shows high-grade serous carcinoma of the ovary. She undergoes a routine chemotherapy post-operatively and is also referred for genetic counseling and germline testing. Now the question is, would you get such a patient tested for germline susceptibility to ovarian and perhaps some other cancers? I trained in the 90s at AIIMS in Delhi, and then as well as until about 7 to 8 years ago, most such patients would not have undergone germline susceptibility testing. But now we have new data, and let me start with this Asian data from Japan in 2015. And you can see they have a small number of cases of ovarian cancer as well as breast cancer. And what is shown here is that even in individuals without a family history of any cancer, there was a 10% incidence of having a pathogenic mutation in the germline that predisposed to one of these cancers. This is another study published a few years ago in the New England Journal of Medicine, and this is in pediatric patient population. And you will note here that these are patients who did not necessarily have any family history, and about 8.5% had a mutation in a cancer predisposing gene. So this is some data on ovarian cancer from India. This was a multi-center study that was sponsored by AstraZeneca. And you can see that 10 Indian centers participated in this study. And what was done was to take consecutive patients with ovarian cancer, regardless of their histology, regardless of their family history, and test them for germline BRCA1 and BRCA2 mutations. And as expected, the overwhelming majority of this cohort, about 85%, did not have any family history of breast or ovarian cancer. But let me show you the results. In patients who had a family history, the proportion who had a pathogenic mutation was almost 55%. But even in those without any family history, you will note that almost 20%, one-fifth, had a pathogenic germline mutation in either BRCA1 or BRCA2. Now, 20% means 1 in 5, and this means that family history is not a good way to exclude patients from being tested for germline mutations. In this study, we also looked at the correlation of histopathological features of the ovarian tumor with the presence of germline BRCA mutations. And you can see here that almost one-fourth of patients with serous cancers had the BRCA mutation, 2 out of 19 with endometrioid cancers, but no patient out of the 15 with clear cell or mucinous carcinoma had any pathogenic mutation. This is an old and a very important study from Australia, again in patients with ovarian cancer. And you can see that in their particular cohort, 20% of all their ovarian cancer patients had germline BRCA1 and BRCA2. They looked at the prognostic significance of having a germline mutation. And you can see here that patients with a BRCA mutation in the germline had better outcomes in terms of both progression-free and overall survival compared to patients who did not have these mutations. So now the question is, should all patients with ovarian cancer be tested for germline mutations? And of course, there is no one correct answer to this question. It depends on the resources that we have. It depends on how uh, with what resources are we able to test our patients. But currently in Western countries, at least for ovarian cancer, it is now becoming the default setting to test all patients with non-mucinous histology for germline mutations. But in our country and in many of our centers, we do try to enrich the population by either family history or age or histopathology or some combination thereof to test for these mutations. Um, I want to share with you another study that was conducted by the group at AIIMS, and they did a very similar study, but this time in breast cancer, and they looked at consecutive breast cancer patients and tested them not only for BRCA1 and BRCA2, but they did a multi-gene panel testing for 107 genes. And they also had 236 patients. And you will note here that the pathogenic mutations were found in 18.64%. So very similar proportion to the ovarian cancer study where the overall proportion was 21%, about 18%, again close to 1 in 5 patients, all comers with breast cancer in India had these mutations. And these were not only the predominant mutations as expected were in BRCA1 and BRCA2, but you can see the sprinkling of other genes such as P53, RAD50, RAD51D, etc., and so on that were also present. And very importantly, they also found that although family history, for example, by NCCN or by some other criteria, although it enriches the population with BRCA mutations, even those without such criteria in their series 7% did have these mutations. So the presence of risk features as well as family history does not completely exclude the possibility of these mutations. So overall, if I just generalize to almost all cancers, about 5 to 10% of cancer cases could have a strong hereditary component. Another 15 to 20% would have a weak familial or a multifactorial etiology, and about 70% are thought to be sporadic. In terms of only BRCA1 and BRCA2, you can see that they predispose not only to breast and ovarian, but to several other cancers that are listed on this slide: male breast cancer, prostate cancer, pancreatic cancer, and recently some other cancers as well. And they are what are called the classic susceptibility high penetrance genes. And individuals who carry mutations in one of these genes have a very high lifetime incidence of breast or ovarian cancer. So let me come to some concepts. I have repeatedly uttered the word germline, and there is a corresponding term called the somatic. And I know that almost all of you know about it, but nevertheless, it's good to revise because this is something that we will hear repeatedly, not only now, but in the years to come. Uh, so each individual inherits one copy of any gene, and there are two alleles of each gene from the mother and from the father. And in this example, let us say that for this particular gene, one of the alleles in the father carries a germline mutation. Now, when you combine one of the alleles, one of the two alleles from the mother and one of the two from the father, there are four possibilities. And of those four, two possibilities, that is 50%, are those wherein the child also inherits the defective gene from the father. So the first thing is that for an autosomal dominant disease like or for autosomal dominant genes, there is a 50% chance of expressing the phenotype in any child, and there is a 50% chance that they are normal. So if the child is normal, or if an individual carries normal copies of normal alleles, then both the alleles need to be hit or mutated in the individual during their lifetime for the cancer to start. But if one gene is already defective, then only there needs to be a single hit, or for example, by loss of heterozygosity and other mechanisms that needs to occur in order for cancer to start in that individual. And this is important. It is basic, but it is important because when I counsel my patients to get their children or their siblings tested, they are often scared because they feel that if they have the gene, then all their relatives will necessarily carry the pathogenic mutation. And it is good to tell them that there is only a 50% chance in the children and siblings having the same pathogenic mutation in that gene. So germline mutations by definition are passed on to the progeny, and they live on those mutations in the genes, they live on in the future generations, and which is why they are important. Somatic mutations, on the other hand, do not occur in the egg or the sperm of an individual. They occur only in the cancer tissue. And of course, cancer cells also divide and they form their progeny, but the progeny is only within that tumor or in the metastatic site and is not passed on to the offspring of that individual. So in that sense, the somatic mutations eventually die with the individual who carries those mutations. So how does one test for germline mutations? There are several tissues that can be used: saliva, blood, buccal smear. Blood is very commonly used, and one extracts the DNA from the nucleated cells in the blood to carry the germline testing. And a few years ago, it was de rigueur to test only for individual genes, but now typically patients are tested using a panel that comprises of 25, 30, 50 genes, and you can sequence all these genes at one go to look at the hereditary predisposition pattern. A number of commercial tests are available. Some academic institutions like Tata Memorial also conduct these tests. And of course, I'm sure Dr. Rajiv Sarin has told you that the net outcome in each gene can either be positive for a pathogenic or likely pathogenic mutation, it can be completely negative, or there can be a variant of unknown clinical significance, which is treated as negative until further information is available. So we have to, I mean, I don't know whether you will believe it or not, only one company in the world, that is Myriad Genetics, had the license to perform BRCA testing up until 2011, when the US Supreme Court ruled that genes are created by God and no company can patent the gene. So only after this was BRCA testing and in general germline testing began to be more widely available all over the world, including in India. So one theme that is very intimately linked to the question of germline predisposition is what is called DNA damage repair. So our DNA continues to get damaged throughout our lives by a variety of insults such as radiation, carcinogens, etc., tobacco, and others. But our system has evolved mechanisms called DNA damage repair pathways that with exquisite fidelity can repair that DNA. So there are two types of DNA damage that can occur. One is single strand DNA breaks and the other one is double strand DNA breaks. So the repair pathways for single strand DNA breaks are called mismatch repair, nucleotide excision repair, single stranded break repair. And in general, these repair pathways are less accurate than the double strand DNA pathway, repair pathway that I will just tell you about. But very importantly, you will note that a large number of hereditary syndromes and predisposition syndromes actually belong to genes in the DNA damage repair pathway. And I just highlighted this mismatch repair, and you will note that the four genes that are listed here, essentially, when a mutation occurs in one of them, then individuals suffer from what is called the Lynch syndrome, where they are predisposed to endometrial, colon, and some other cancers. And one important mechanism of a single strand repair is what is called single stranded break repair. And I have highlighted this in red, the enzyme PARP1 or the poly-ADP ribose polymerase. This is an enzyme that is involved, and this is important because I will just tell you about its clinical significance. On the other hand, DNA double strand DNA damage can actually be repaired by either the homologous recombination pathway or the non-homologous end joining. And out of this, the homologous recombination repair is the most accurate way of repairing the DNA. And you will see here that some of the genes and several other genes that are listed here are involved in this particular pathway of DNA repair. And again, this brings us back to the point that many hereditary syndromes actually occur because of germline mutations in the genes that are involved in DNA repair mechanisms. And here it is the homologous recombination in BRCA1 and BRCA2. So in terms of homologous recombination, which I said is the most flawless way of repairing DNA, some causes are known like germline BRCA1, BRCA2 mutations. These genes can be silenced in the tumor by methylating the promoter of these genes. So even though the DNA is present and it is normal, the gene is silenced. And then, of course, there are undetermined causes of homologous recombination repair that are yet to be discovered. But very importantly, apart from BRCA1 and BRCA2, all these other genes are also involved in DNA repair, in homologous recombination repair, and hereditary mutations in one of germline mutations in one of these genes can also predispose individuals to ovarian and some other cancers as well. So I told you about homologous recombination repair. Now, how can deficiency of homologous recombination repair be detected? It can be by either, for example, if it is due to a mutation in a gene, you can sequence the gene and find out the mutation. You can actually do a functional assay. You can have DNA, you can try to repair it by the enzymes that are present in an individual, which is called a functional assay. It's very cumbersome, time consuming, and very requires high expertise, so not very often done. But the best way to, or an important way to look for a deficiency in homologous recombination repair is to look at the effect of homologous recombination deficiency, which is that when the double strand DNA break repair mechanism is deficient, then there is widespread DNA damage in that person's genome. And can you look at the scars of that DNA damage, which would ordinarily not accumulate in a person with normal homologous recombination repair, but these scars or genomic defects will accumulate in somebody who, or in a tissue that has deficiency of homologous recombination repair. And what can be done is to look at these genome-wide genomic aberrations in that person's tissue. And what I've highlighted here are three such abnormalities called loss of heterozygosity, telomeric, allelic imbalance, and large-scale state transitions. So don't worry about the jargon. This essentially means that there is widespread DNA damage throughout the genome in that tissue of that individual because homologous recombination repair is deficient. Another way to look at it is by whole genome sequencing. And you again, what is listed here are genomic abnormalities that accumulate in the tissue of that individual because homologous recombination repair is deficient. So how do you find out that homologous recombination repair is deficient? You look for the effects of that deficiency throughout the genome of that tissue. And you can also look at the mutations of the genes that might have caused that homologous recombination repair deficiency. So if I come to ovarian cancer, as I told you, our data and other data shows that about 15 to 20% of patients will have a germline defect in one of the repair genes like BRCA1 and BRCA2, but more than 50%, about two-thirds, close to two-thirds, will have a homologous recombination deficiency of some other cause. For example, silencing of these genes in the tumor tissue despite the germline being normal or some other unknown causes. And so therefore, this pattern of DNA repair deficiency exists in ovarian and some other tumors in a large proportion of cases. So I have told you that DNA repair deficiency due to homologous recombination deficiency can occur in many tumors, either inherited in the germline or acquired. Now the question is, can you therapeutically exploit this deficiency? So I told you that one of the ways of repairing single-strand DNA breaks is by an enzyme called PARP, poly-ADP ribose polymerase. And what this does is, in the second panel, in the second figure here, you can see that there is a break in the DNA. PARP latches onto that defect. It recruits the other healing enzymes. And once those enzymes have repaired the DNA, the PARP detaches itself and the DNA is repaired. Now, what happens is that if the PARP gets stuck to the DNA, then the replication fork or the repair mechanism cannot proceed. And the way in which PARP inhibitors, and you know that PARP inhibitors have become a very important way of treating at least some cancers. The way they inhibit PARP is to inhibit PARP from detaching itself from the repaired DNA. So PARP gets stuck there, and therefore there is a collapse of the replication fork, and the DNA cannot repair itself. So please take out 2 minutes to understand this. This is the basis of PARP inhibition in ovarian and some other cancers. So in the normal cell, the double strand and the single strand DNA repair mechanisms are normal and the cell is viable. Now, if you have a normal cell and you add a PARP inhibitor and you inhibit the single strand mechanism of repair, what will happen is that the double strand DNA repair mechanism is still intact, and therefore the cell will still survive and nothing will happen to that cell. Now, if you have a cell that is inherently deficient in the double strand DNA repair mechanism, it will still survive because the single strand DNA break repair will take care of a large number of DNA damage that occurs. But when you have a cell that is inherently deficient in the double strand DNA repair mechanism, and on top of that, if you also inhibit the single strand DNA repair mechanism, then the cell dies because both mechanisms. So this mechanism is already deficient and you knock out this mechanism by a drug. So then the cell dies. And this is called synthetic lethality. So synthetic lethality means that the PARP inhibition will be lethal to the cell only in the presence of a defect in the double strand DNA repair mechanism due to BRCA or some other cause. So this is not just theory. This is one of the most highly cited papers about 15 years ago by Hannah Farmer and colleagues. And you see, this is on the right is wild type BRCA wild type cell, and on the left is BRCA mutant cell, and the x-axis is actually a log scale. So BRCA mutant is 1,000 times more sensitive to PARP inhibition compared to a BRCA wild type cell, and this was in a cell line. So based on this mechanism, a number of drugs have been discovered, which are listed here. They are called PARP inhibitors. They differ in their potency and in their ability to inhibit PARP by trapping PARP on the DNA, but they work by more or less the same mechanism listed here. So let me give you a few glimpses of the results that have been obtained until now. And I've already told you that why would PARP inhibitor work in ovarian cancer? About 15 to 20% of the cells have a germline defect in double-strand DNA repair, and another 30 to 40% patients have a deficiency in homologous recombination repair due to some cause in their tumor, although it is not germline. So almost 50 to 60% of patients would potentially be sensitive to PARP inhibition in ovarian cancer. These are the results of using PARP inhibitor in patients with relapsed ovarian cancer who had a germline or somatic BRCA mutation. So this is only patients in whom the BRCA1 or BRCA genes are defective either in the germline or in the tissue. And you can see here these are 3 drugs, and these are the results of using PARP inhibitor versus placebo. And you will note the results. It is 5.5 months versus 19 months. It is 5.5 months versus 21 months, and so on. So actually the progression-free survival is nearly tripled to quadrupled with the use of PARP inhibitor, and the absolute benefit is like anywhere between 12 to 18 months. So a big benefit in arresting the progression of the disease when you use PARP inhibitors in recurrent ovarian cancer in patients with either a germline or somatic BRCA mutation. Now, what happens if you use the same drugs in patients without a germline or somatic BRCA? So the BRCA genes are intact here. And you will note that although the same 3 drugs, these are the results, the magnitude of benefit is either non-existent or very little. So the cell line result that I showed you from Hannah Farmer and all the theory that I've been telling you is not just theory, but actually it pans out in actual practice that PARP inhibitor works best and most effectively in patients with homologous recombination repair deficiency, but not in patients with an intact double-strand DNA repair mechanism. So now these drugs have been used in the first line setting in ovarian cancer. This is the most important trial, the SOLO-1 trial. And these are patients who had a BRCA mutation, either in the germline or somatic. And after receiving the first line treatment with surgery and platinum chemotherapy, they were randomized to receive either olaparib or placebo. And you will note here that the difference in the progression-free survival is big and is huge. At 36 months, it is 60% progression-free versus 27% progression-free. So a big benefit of PARP inhibition in patients who carry the germline deficiency in either germline or somatic defect in one of the BRCA genes. And these are the updated results. you can see that the median progression-free survival has increased from 13.8 months to 56 months. Now, some of you might know about the usual results in cancers, and the progression-free survival is usually increased by about 20% or 30%. Here, there is almost a 400% increase in the progression-free survival. And this means that all the theory that I have discussed with you and all the previous results actually are correct, and and actually these drugs work by the mechanism by which they are expected to work. So of course there is no free lunch and nothing comes for free. These drugs are not without toxicity, nausea, fatigue, vomiting in a substantially high proportion of patients, significant anemia, and we have experienced this in our patients as well, neutropenia in some patients, and a fair proportion of patients, about 12%, need to discontinue the drug because of toxicity. Uh, uh, Other drugs, the Feliparib, Niraparib, as well as Olaparib, I've already told you, all three of them have been tested in the first line setting. And essentially, the results have been that in patients who have a mutated BRCA, either in the germline or in the somatic tissue, or have a homologous recombination deficiency, benefit markedly from the use of these drugs in the first line setting after platinum therapy. And again, I will not read out the actual numbers. I've highlighted them here, but there is a marked big improvement in the outcome in progression-free survival in both of these groups. But this last group that I'm just now highlighting is individuals without BRCA mutation, without homologous recombination deficiency, and you see that the benefits are either non-existent or much smaller. One other toxicity of PARP inhibitors is myelodysplastic syndromes or acute myeloid leukemia. Happens in a very small proportion of patients, but nevertheless, something to think about when we clinically use these drugs. And apart from that, of course, there is financial toxicity. They are expensive, including the Indian generic drug that has been launched recently. So this is also something to be considered. But with all of these caveats, I think PARP inhibitors are one of the important advances, recent advances in the treatment of ovarian cancer. And I think these drugs will become increasingly used. They are already widely used elsewhere in India. As the price drops, as they become more accessible, they will be more widely used in patients who have a defect in double-strand DNA repair. So very briefly in breast cancer, again, this is a triple negative breast cancer and the use of a DNA damaging agent like platinum. So essentially, platinum and PARP inhibitors more or less work by similar mechanisms. I will not say same, but similar mechanisms. So both of them damage the DNA because they inhibit DNA repair. And if the DNA repair is already knocked out for some reason, then they are even more effective. And this is a small study from Poland, which showed that the highest effectiveness of cisplatin in breast cancer was actually in patients who had a BRCA mutation with an 83% pathological complete response. This is the JEPAR 6 study, and the best benefit of platinum in terms of pathological response was in patients who either had a BRCA mutation or who had a family history of breast or ovarian cancer, again attesting to the fact that if the DNA repair is already defective in a person's tumor, then you add another mechanism of DNA damage, it is bound to be more effective. This is the corresponding to the recurrent ovarian cancer. This is metastatic breast cancer. This is Carboplatin versus docetaxel, both effective drugs. The TNT trial, the overall trial results showed that both are equivalent in terms of efficacy. But when you break down the results by BRCA mutation, you see that platinum is actually more effective than docetaxel, both for germline as well as for tumor BRCA mutation. Again, re-emphasizing the fact that the mechanisms by which these drugs work is actually a DNA damage, and they are more effective when the DNA damage repair mechanism is already knocked out in a tumor. One thing that all of us should consider is that when a person carries a germline BRCA mutation, they carry that not only in their tumor tissue, but in every single cell of their body. So actually the hematopoietic cells, the other cells also carry the germline BRCA mutation, and therefore it is my experience and also reported by many others that the toxicity of chemotherapy is also higher in patients who have a germline defect in double-strand DNA repair, BRCA mutation, or some other cause. So one has to be cognizant of the fact that although DNA damaging agents are effective in these patients, they are also likely to be more toxic. Again, PARP inhibitors have been used in patients with metastatic breast cancer. This is the OlympiAD trial, where olaparib was compared in metastatic breast cancer patients to treatment of physician's choice, and they did not include platinum in the treatment of physician's choice, which in my opinion was a way to weaken the control arm of this study. But nevertheless, with that caveat, some benefit in progression-free survival, but you will immediately note that the magnitude of benefit here is far, far less than in ovarian cancer. So both were patients with germline BRCA mutation, or BRCA that was knocked out in the tumor for some reason, already knocked out. But in ovarian cancer, the benefit is much higher than in breast cancer, attesting to the fact that it is not only the genetic defect, but also tumor microenvironment and other tumor-related factors that are involved in the effectiveness of a particular drug. Overall survival not markedly different and not significantly different between olaparib and chemotherapy. Some benefit in health-related quality of life with PARP inhibitor compared to chemotherapy. And this is the other drug that has been used in patients with breast cancer, talazoparib. Again, compared with treatment of physician's choice in patients with germline BRCA mutation. And again, if you see, there is some benefit in progression-free survival, far less than what was the case in ovarian cancer, but no significant difference in overall survival. So again, with some benefits in health-related quality of life with talazoparib uh, compared with chemotherapy. So overall, PARP inhibitors are, I would not say that they are ineffective in breast cancer, but they are less effective than in ovarian cancer, and there is some possible benefit compared with chemotherapy in terms of side effect and quality of life. So they are one option of treatment in patients with breast cancer. But like with every disease, once you've tested a drug in the metastatic setting, then you want to test it in the non-metastatic setting, and that is where the real benefit lies, because you are not merely prolonging the life of a patient, you're curing more patients if the drug is effective. And this is the OlympiAD trial. Uh, these are patients with relatively high-risk breast cancer with either a germline with a germline BRCA mutation, and you see that 80%, more than 80% of these patients had triple negative breast cancer. There is almost a 9% improvement in disease-free survival with the use of olaparib in the adjuvant setting after the completion of chemotherapy. And there is a trend to improvement in overall survival. Now, this is what I would say is a more important result compared to the metastatic setting, because in patients with triple negative breast cancer, if you've improved their disease-free survival by about 8 to 9%, that's a real important result. And I think this is already begun to be used by some of us, not in the majority of patients because of cost issues, but I think this will become more widely adopted as we go by. But of course, the absolute requirement to implement this treatment is the need to be able to perform germline testing for many of our patients or all our patients with breast cancer. So pancreatic cancer, I told you that pancreatic cancer is one of the cancers that happens due to BRCA2 mutation. Only a small percentage of patients with pancreatic cancer actually have these mutations, but it is important to test for this mutation in patients with CA pancreas. It was never on our radar screen for all these years, but now because we have PARP inhibitors and because there is a therapeutic implication, I think physicians are becoming more and more cognizant of the necessity to perform these tests. This is the POLO trial. Again, very similar in design to the ovarian cancer studies. This is maintenance olaparib for germline BRCA mutated metastatic pancreatic cancer. Like in ovarian cancer or like in recurrent ovarian cancer, these patients had already received one of the platinum-based treatments and were either in response or at least had stable disease after most recent platinum therapy. And then you see if you gave olaparib, the progression-free survival is substantially improved. And even though you may say that this is 3.8 months versus 7.4 months, but in a disease like pancreatic cancer that has a high proportion of fatality, this is quite a, in my opinion, this is quite a significant and a clinically meaningful result. And you can see that at 24 months, almost 22% of the patients were progression-free compared with 9.6% in the control arm, which is, I think, something that is clinically meaningful and useful. There is no difference in the overall survival between the two arms. And this is also the case with updated survival results that I'm not presenting today for want of time. But this just suggests that you could either use olaparib or DNA damaging agent right then at the end of first line chemotherapy, or perhaps you could use it in the future at some point of time. Colon cancer. Now, many of you know that Lynch syndrome is associated with colon cancer, and Lynch syndrome, as I told you, is again due to uh, a mutation in one of the 4 genes that are involved in mismatch repair. And that is another mechanism of single strand DNA repair. And uh, essentially what happens is that when these genes are defective, either in the germline or if they are knocked out for some reason in the tumor, again, very similar to ovarian cancer, very similar to homologous recombination deficiency, but this is not homologous recombination. This is mismatch repair deficiency, another mechanism of DNA repair. This is single strand DNA repair. So either the germline genes can be mutated, or for some reason these genes are normal in the tissue, but they are silenced. And the net result is that you have a deficiency of mismatch repair. And what this leads to is what is called microsatellite instability. So these satellites are at the end of chromosomes and they accumulate DNA damage. And so there is a high rate of microsatellite instability. And you can measure that either with immunohistochemistry for these 4 genes, or you can do PCR for the microsatellite markers, a set of 6 PCRs. And essentially in colon cancer, it has been a long-standing observation that tumors, about 15% of all tumors that carry the mismatch repair deficiency are less responsive to chemotherapy. But it has also been shown in many tumors, not only in colon cancer, and this was one of the first reports in NEJM about 6 years ago, that tumors that have this mismatch repair deficiency are more susceptible to immunotherapy with the immune checkpoint inhibitors, either PD-1 or PD-L1 blockers. So you see here that there is a nice response in these tumors that have the mismatch repair deficiency, and this is the updated report from the same group. Um, so I told you that in 15% of colon cancers have the MMR deficiency or MSI high tumors. And in these tumors, in the metastatic setting, they were randomized to receive pembrolizumab, which is the immune checkpoint inhibitor versus chemotherapy. And again, you see that there was a marked benefit of pembrolizumab compared with chemotherapy, at least in terms of progression-free survival. And the delta is quite large. So therefore, in my opinion, this is also clinically meaningful. So until now, I have told you about the therapeutic implications of germline testing, which means that until now, germline testing was essentially meant until a few years ago because you wanted to then test the family members, the children and the brothers and sisters, and wanted to find out whether they also have the mutation so that some preventive surveillance can be carried out. But in the past about 30 minutes, I have told you that now there is also a treatment implication of germline testing. But now I'm going to tell you what I'm going to give you an example is that there is a germline implication of therapeutic testing, the reverse. So I just told you that microsatellite high tumors actually in a proportion of them or in some fraction of them, the germline MMR genes, the 4 genes that are responsible for MMR are mutated. So we know that pembrolizumab has been approved because immune checkpoint inhibition is more effective in patients whose tumors have MSI high, microsatellite instability high. So now the question is that when you are encountered with a patient which has who has a tumor that is MSI high, should you do the germline testing to find out whether they have the Lynch syndrome? And you see this shows you the proportion of tumors, and these are all tumors in which MSI is high. So for example, in endometrium, it is close to 17%. In uterine sarcoma, it is about 3%, etc., and so on. So this is a study from the Memorial Sloan Kettering, and they looked at all MSI high tumors who had not yet had a germline testing, and they just had a MSI high tumor, and the reason why MSI was tested was to treat them with the immune checkpoint inhibition. And you see here in MSI high tumors, almost 16% actually carried the Lynch syndrome. So I had a patient, I tested the MSI because I wanted to give them pembrolizumab. The MSI turned high. Then because the MSI was high, I did the germline testing and I found that 16% of such patients had the Lynch syndrome. And you see here in these, more than half or almost half of these patients had cancers other than colorectal cancer or endometrial cancer. So this is the germline implication of somatic testing, the reverse. Initially, I told you treatment implication of germline testing, but now I'm telling you the germline implication of treatment testing. So essentially, we should possibly test for germline Lynch syndrome in all patients with MSI high tumors. So let me conclude, and I think I took more time than I had originally intended. I think it's about 40 minutes that 50 minutes that I've been speaking. So I'll end. I think all of us will appreciate that germline and somatic testing and therapeutic testing are closely linked and intertwined with each other. They are no longer separate silos, and clinicians have become increasingly aware of germline nuances because of the treatment implications. And of course, we have to thank the US Supreme Court that lifted the patent on Myriad Genetics, who was the only company in the world which was authorized to do the germline testing not until very long ago. So thank you very much for your attention, and I will be happy to answer the questions that have been put up in the chat box. So let me stop sharing my screen.
Superb talk. I'm mesmerized. I'm glued. So much I've read about it, but the way you analyze, that's what I love about it. The simplicity, you boil it down. I would have read a trial, but then I hear you in a conference interpreting it. Then I could just see how nicely you break it down and make it very simple. Not only for students, for all the practicing physician and people who have read about it. Still, the way you put it is outstanding. Such a vast knowledge, so beautifully, practically you put. Thank you very much. There are a lot of
Thank you.
questions in the chat box.
Yeah, thank you very much, Dr. Somashekar. I'm sure you are very kind to me. I don't deserve all the praise that you are lavishing, but nevertheless, I will take it with all humility. So
Thank you.
I think there are some questions. What is the difference between familial and hereditary cancer? So I think they are sort of more or less they are closely linked to each other. Hereditary is a more definitive term where we say that there is a definite inherited predisposition to cancer because of a mutation in a gene that predisposes. Familial means that although there may be a familial component, uh, it is not been discovered to be due to a defined abnormality in this particular individual, and one cannot rule out the combined effect of hereditary and acquired components or environmental components. So familial is a more diffuse term where so for example, if you have a patient, and I have some patients, Dr. Somashekar would also have some such patients, where 4 or 5 or 6 family members have a family history of some kind of cancer, but you repeatedly test their germline and you find that there are no mutations. So this is likely to be familial, but one cannot call it hereditary with a uh, definitively hereditary. So familial and hereditary are related, but they are slightly different from each other. So the next question is, what is the role of non-homologous end joining pathway in human beings? So it is another way of repairing double-strand DNA breaks, and it works differently from the homologous recombination repair deficiency. It is involved in repairing uh, more bulky lesions in the DNA, and sometimes these DNA repair mechanisms work in sequence rather than simultaneously. So, if non-homologous end joining is already largely repaired a defect, then it can be proofread later on by or on another occasion by the HRR pathway to see that the DNA is repaired with high fidelity. I must add that non-homologous end joining is a more error-prone repair mechanism compared to homologous recombination repair, which is the most flawless way of repairing DNA. So the next one is from Dr. Veena Rajan. Thank you for an informative talk. Would you please explain again how is HRD tested? So homologous recombination deficiency. Essentially, you have a tumor tissue. You want to know whether the mechanism of DNA repair called homologous recombination, which repairs the double-strand DNA break, is actually defective in this particular tissue. So what would you do? You would there are two ways of looking at it. The first way is that you can look for a mutation in a gene that is involved in homologous recombination repair. And if there is a pathogenic mutation in that gene, you straight away know that this tumor has homologous recombination deficiency because the mechanism itself is deficient. The second way is that you have tested for the mutation, but you found no mutation. But like I told you, the absence of a mutation is not synonymous with a normal repair mechanism. It could still be defective because the gene is silenced. So then what do you do? What will homologous recombination repair deficiency lead to? What it will lead to is errors in the DNA throughout the genome. So what you do is you try to detect these errors in the genome. And how you test for these errors in the genome? You look for DNA breaks, as in large scale state transitions. You look at you use a SNP array, a single nucleotide polymorphism array, to look at loss of heterozygosity, which is genome wide. So on all chromosomes, if there is widespread loss of heterozygosity, you know that for some reason in this tissue that the homologous recombination deficiency or repair pathway is deficient. uh, you can look at some mutation signatures. So, for example, if the normal mutation rate is, let us say, 4 per megabase, then if the mutation is much higher in this tumor, you know that maybe the DNA repair mechanism is deficient. So essentially, you look for the effect of homologous recombination repair deficiency. So I'm not sure if I've been able to explain it to you, and believe me, it is very hard to understand because I also read it and reread it and reread it and reread it. And only now I think I begin to understand it. I've still not understood it fully. So I suggest that you look up a review article in the ESMO Open. It was recently published in the ESMO Open journal, and that has a very nice description of the ways to detect homologous recombination repair deficiency. Why don't PARP inhibitors work in platinum-resistant tumors? So I told you that essentially the way I look at it is that these PARP inhibitors are like oral platinum, or I could say that platinum is like intravenous PARP inhibitors. And what platinum resistance tells me is that the the presence of a double-strand DNA repair deficiency in this tumor has already been bypassed by the tumor by some way. So, for example, one way of doing that is that if there was a BRCA mutation which knocked out its function, there is something called a reversion mutation, so which can restore the function of the BRCA gene in that tumor. There are other mechanisms. For example, if some of these genes were silenced by methylation, then you know that methylation is taken off by the tumor during its evolution, and those genes become reactive again. So what that will lead to is that the tumor has a heightened or a better ability to repair DNA damage. And as soon as the tumor acquires an ability to repair its DNA better, it will become resistant to both platinum as well as to PARP inhibitor, because both of them work by essentially damaging the DNA. So platinum resistance is a kind of a functional test to test the functional way to test the the ability of the tumor to repair its DNA. And if that DNA repair mechanism works better and better in the tumor, it becomes more and more resistant to these treatments. Are all BRCA mutations associated with HRD? So yes, the answer is yes, that if there is a pathogenic or a likely pathogenic mutation in BRCA1 or BRCA2, which has knocked out their function, then yes, those tumors will be homologous recombination deficient. So, in government setup where poor patient has to pay from pocket, which testing should we offer in non-mucinous ovarian cancer? So my answer to that question from Dr. Shikha is that, even in Tata Memorial Center, we currently don't test all patients because of a variety of reasons. It is very difficult to test all patients. So what we do is we still use some sort of markers of a high probability of these germline mutations, like family history, young age, some particular types of histology. And I would say that a combination of age and family history are reasonably good ways to get the most bang from the buck. So Dr. Dhara Pandya has complimented me. Many thanks, Dr. Dhara Pandya, for your appreciation. I'm glad that you liked my talk. Dr. Shiv, what are testing samples used for germline and somatic? So for germline, I told you it can be saliva, it can be buccal mucosa, it can be nail clippings, it can be blood. So all of those tissues can be tested because all of those will carry DNA that is not tumor DNA. So essentially germline means that person's normal tissue DNA, and somatic means tumor DNA. So the samples, so in a patient with ovarian cancer, the blood is not involved, the buccal mucosa is not involved, the GI epithelium is not involved, the nails are not involved. So if you extract the DNA from any of these tissues, that will serve as the germline DNA and you can do the mutation testing there. Somatic means tumor. So if you have a patient with breast cancer, ovarian cancer, pancreatic cancer, colon cancer, whichever cancer, you have to put a needle within the tumor, take a biopsy, take a tissue from within the tumor, and that is somatic. And the implication is that germline, like I told you, exists in every single cell of the body. So a mutation that is found in my buccal mucosa will also be found in my myocardial cells, will also be found in my hair, will also be found in my nail, will also be found in my skin, will be found everywhere, because that has come from the single zygote from which I was eventually made. Uh, Dr. Veena Rajan says your cause and effect explanation is clear. Nobody can simplify it. Thank you very much, Dr. Veena Rajan. I'm really very thankful to you that you liked my talk. Thank you so much. I think I have more or less covered. Let me click on the Q&A. If there is anything there, I can't see anything there. Yes, there are one or two more questions, which I will quickly. When to order germline or somatic testing? So this is dependent on the context. So in tumors like, for example, the ovarian tumor, where there is a high benefit of some of these treatments, I think germline or somatic testing should increasingly be offered to many more patients. But I have already said that may not be feasible in every single patient. What tests are available in India for Lynch testing? So it's a germline testing. So I can take my blood, I can send it to one of the labs, or I can do it within TMC, and I can test it for a panel of 25 or 30 genes, four of which genes are the Lynch associated genes which are involved in mismatch repair. So I listed out the four genes that are involved in mismatch repair deficiency. They are the ones that will be tested in my blood to look at the mutation. The very last comment that I want to make is that I think one big theme, or one big a point from my talk and otherwise, is the fact that you will appreciate that for some reason the genes that are involved in DNA repair, be it single strand DNA repair or double strand DNA repair, are the ones that are most often associated with these hereditary syndromes. So, that is, and so that is why the therapeutic exploitation, whether it is by PARP inhibition, whether it is by immune checkpoint inhibition, is essentially closely intertwined with the DNA repair mechanisms. So my request to all of you is that please go back and read one of the good review articles on DNA repair, because that will be very important for all of us to understand in the years to come about how to integrate these treatments. So I think I've covered almost everything.
There is one more question somebody has asked. We know that if BRCA is not mutated by germline or somatic, then we go to HRD. But does all BRCA mutated patient also have HRD?
Yes, that is absolutely correct. All pathogenic or likely pathogenic mutations of BRCA are by definition HRD. So the way I do it is HRD testing is far more expensive than BRCA testing. So what I will do practically in my scenario is not to do the HRD testing first, although that may also be a strategy if resources are not a limiting factor. So I will first do BRCA testing in the germline, which is the cleanest and the most inexpensive way of testing it. If that is positive, then by definition the tumor is HRD positive. And then you don't need to do any other fancy test that I told you about. If BRCA is negative, then the tumor may still be HRD positive. In that case, you could either do only somatic BRCA, and then if somatic BRCA is mutated, then again HRD positive, then no need to do that big whole genome thing that I told you about. But if both germline and somatic BRCA are negative and the other genes that are involved in HRR like RAD51, etc., are also not mutated, then you could do that HRD score or HR detect that I told you about, and then you will pick up an additional 15-20% patients which are HRD. So by definition, if BRCA1 or BRCA2 or one of the other genes are mutated which are involved in the repair mechanism, then the tumor is HRD, and then no need to do the HRD.
Superb. I would also request all the students, June 2021, see Global JCO, Sudeep's article, on what is the prevalence of BRCA in unselected cohort of Indian ovarian cancer patient. It is available. You can go and download, and also in Twitter, it was very well covered. It's a very good article. It's not just about knowing the prevalence, which Professor Sudeep has published, but also the background and the discussion part. That's a very good article I usually keep as a reference for my students. So all of you, please go back and see that. In case you are not able to locate, write to me or to Sudeep. I'll send a copy of it, but it's easily available everywhere. Sudeep, thank you very much.
Thank you.
You are a super hit. You should
Thank
do a oration on that for us. And the people are overwhelmed, and they'll not let you go. But as I always say, all good things has to come to an end. And no one person can ever cover such a vast the way you did in 1 hour. Our aim is to always show the direction, stimulate their mind, show the path. They have to walk and do. We can't spoon feed them, but superb. My heartfelt thanks to you. Fantastic session.
Thank you very much, Dr. Somashekar and Dr. Navneet Singh also. And thank you so much to all the attendees for logging in so early in the morning. Thank you so much. Bye-bye. Take care.
Thank you very much,
Thank you.
Professor Dr. Sudeep Gupta,
Thank
for
you.
the presentation. And thank you very much, Professor Dr. Somashekar, for joining us. And thank you, trainees and faculty members, for joining us.